treating the difficult asthmatic. How do we go about doing that? And that raised a number of questions. Is asthma difficult? And is it the asthma that's difficult, or is it the asthmatic that's difficult, or is it difficult because it's not asthma? And what I'm going to do is show you some examples of each of these. So, first of all, let's just very briefly, I want to go over what are the basics of successful asthma treatment. And of course, recognition is very important. You've got to recognize, if you don't recognize it's asthma, you don't treat it properly. You need to classify it by clinical pattern. There are patients who have intermittent from specific environmental exposures. The more common pattern is intermittent viral respiratory infection-induced asthma, which isn't going to be benefited by maintenance inhaled corticosteroids. And then you have chronic or persistent asthma, you've got seasonal allergic asthma, and each of these has different clinical implications. The principles are early and effective intervention for exacerbations with beta-2 agonist bronchodilators, systemic corticosteroids for bronchodilator subresponsiveness, and having those measures on hand with the patients having had adequate instructions as to how to use them, both verbal and written instructions. Continuing on, maintenance medication for chronic or seasonal patterns of asthma are important and not effective for viral respiratory infection-induced exacerbations, even at increased doses. Inhaled corticosteroids, even low doses, are the most effective single maintenance medication for asthma. And adding long-acting beta-2 agonists, salmeterol or formoterol, is more effective on average than increased doses of inhaled corticosteroids, as Dr. Cohen has recently has just been describing. And there's a number of studies demonstrating that. There are, of course, environmental considerations, and early and effective intervention for exacerbations is important, even for patients with persistent asthma that require maintenance medications. So that's a very, very brief overview of the things that work in most patients. For those who want to see more of the recommendations we have for primary care physicians and also education material we use for our patients, because I think that's very important, this website of ours has hyperlinks to both patient handout material and recommendations. It's entitled Managing Asthma for Patients and Families, and also Managing Asthma for Primary Care Physicians Guidelines. But what about when asthma doesn't respond to the basic measures that usually work? So we're going to talk about difficult asthmatic, difficult asthma. One relatively uncommon pattern of asthma that's in the literature is sudden asphyxic asthma. And these are indeed difficult patients, but they're real. This description was used in this publication by Wasserfallen, who described 3 patterns of life-threatening asthma. The most common pattern of life-threatening asthma, and what causes most deaths from asthma, is gradual progression over days, and too little is done too late. Then there are patients that just have basically unstable asthma, and they have acute exacerbations that come on fairly rapidly. But then there's these patients that can go from being perfectly fine 1 minute to rapid decompensation. They've got a high incidence of respiratory arrest, but then they often have rapid recovery. In contrast to the patients who get tremendous amounts of inflammation and have their lungs fill up with mucus, these are patients who appear to have severe acute bronchospasm, and to the extent that it's asphyxic, and yet once they're in an emergency room and they respond an hour or two later, they can be in pretty good shape. So let's look at one of these patients that has some very interesting clinical implications. He's an 11-year-old boy. He's had asthma since infancy. It was initially viral respiratory infection-induced intermittent pattern, but it very quickly became a persistent pattern, and he's had persistent asthma requiring maintenance medication since the age of 2 or 3. And in fact, we'd followed him for quite a while. He was well controlled with maintenance medications and occasional intervention with a short course of oral steroids, but very occasional, until a year earlier. And we weren't seeing him all that often. The mother was going to local physicians a good deal. And he began about a year earlier having acute life-threatening events, generally precipitated from even mild exertion. Mild exertion in PE, walking a couple of blocks vigorously, and it wasn't prevented by albuterol. Now, normally, you've got a well-controlled asthmatic, they take albuterol before PE and before exercise, completely blocks it. Didn't block it at all. He was doing it, and this was a compliant patient. There were multiple 911 calls for severe dyspnea, cyanosis, and loss of consciousness. This kid was scary. He'd had multiple emergency room visits. But didn't have to be admitted. Once he was in the emergency room and they jumped on him and did lots of things, he responded. An hour or two later, he was okay. He had been on inhaled corticosteroids as the only maintenance medication till a year ago. At that point, salmeterol was added as Advair, so it's a combination product, because symptoms had increased. And this was the local physician who started this. And then he started having severity and poor control persisted, despite increasing the Advair to 550, the highest concentration it comes in, twice a day. And this was a good mother and a very compliant boy. This boy did what you told him to do. This was not the usual problem. And there was pretty good documentation of that. His technique of administration was good. His exercise intolerance persisted. And he would keep trying. I mean, it's not a kid who wanted to sit around and look for excuses. He would still try it and do with PE. A few minutes into exercise, that often he'd have to stop or they'd have to call 911. He was having multiple daily uses of albuterol, something he hadn't been having before. And finally, after one particularly scary, life-threatening event, local physician referred him back to us, and the mother was happy to come back to us, although she was skeptical at this point as to whether anything could be done. She was at her wit's end. So we actually, because of the history, electively admitted him to the hospital, not because he was in acute distress at the time, but because the history was so confusing, I didn't think I was going to be able to sort this out on an outpatient basis, and he had nearly died in this most recent episode of the emergency room. So we admitted him to the hospital for further evaluation and management. And whenever we get a history of exercise problems, and if we aren't sure what's going on, we put him on a treadmill and we exercise him. So we did a treadmill exercise test after giving him albuterol, and normally that will totally block it. And his baseline pulmonary function was normal. Baseline spirometry was fine. And what we saw was about 3 minutes. Now, normally with exercise-induced asthma, they'll complete the 6 minutes and then they drop afterwards. This boy, 3 minutes into exercise, he has severe dyspnea and cyanosis, and he has a 70% decrease in his FEV1. I mean, the bottom drops out. He looked awful. His O2 saturations dropped down into the 70s. And we started giving him lots of albuterol, and he gradually, over about 5 minutes, responded. Maybe this was a fluke, so we had him at the hospital, we brought him back, we did it again, same thing, I think we gave him more albuterol the second day. No effect. Still, the bottom dropped out, he looked awful. So, the hypothesis I had, based on this, is that he had downregulation of his beta-2 receptors from continuous stimulation by beta-2 agonist. So what do we do? We discontinued the albuterol. We substituted theophylline, something we don't use a lot anymore. But we knew it was an effective drug. And in fact, there is data showing that adding theophylline to an inhaled corticosteroid has a similar additive effect as adding a beta-2 agonist. But the difference is theophylline isn't a beta-2 agonist. It's not going to contribute to downregulating the beta-2 receptor. And the result was 2 days in a row we had complete blocking of exercise-induced bronchospasm with albuterol, and he got through the not only the 6 minutes of exercise, he went longer and had very little drop, essentially virtually no exercise-induced bronchospasm, and he could tolerate it. Now there's been a growing literature on this subject. Here's some of the references for downregulation of beta-2 receptors by continuous stimulation. Here's one by Israel et al. Effective polymorphism of the beta-2 adrenergic receptor on response to regular use of albuterol in asthma. So there are certain genetic polymorphisms of the beta-2 receptor that appear to make patients not have very prominent downregulation of the beta-2 receptor. There's another one, the arginine 16 beta-2 adrenal receptor polymorphism predisposes to bronchoprotective subsensitivity to patients treated with valmeterol and salmeterol. And another one by Israel and colleagues, use of regularly scheduled albuterol treatment in asthma, genotype stratified, randomized placebo-controlled crossover trial that was in Lancet. So, is this a common phenomenon? No. When you look at multiple studies on average, and this relates to what the gentleman back there said, not all patients are the same, and some of this is genetic. On average, when you add salmeterol to low doses of inhaled corticosteroids, that's more effective than using a higher dose of inhaled corticosteroids. But when you do that, you need to be aware of this occasional problem. And I emphasize it's occasional, it's not frequent, that are they losing their bronchoprotective effect of albuterol, which is so important. And by the way, there's a disconnect between bronchoprotective effect of albuterol and bronchodilatory effect of albuterol, because they don't completely lose their bronchodilator effect, these patients, but they do lose the bronchoprotective effect. So, let's move on. Difficult asthmatic. Different problem. Here's a patient, 15-year-old girl with long-standing chronic asthma, exacerbations frequent with multiple emergency room visits and hospitalizations, despite an optimal management plan. She was on Advair 250/50. She had interventions measures on hand and instructed. And she, acknowledged that she might miss about 1 dose of Advair per week. This is what we got on history. She stated she was pretty prominent. But you've got to have a suspicious mind in this business. And so we called the pharmacy where she got her prescriptions, and we got a printout of pharmacy prescriptions, and she had only filled 1 Advair the following year. Now, even when we confronted her with this, she said, she and her mother got very indignant. Well, are you saying that I'm taking my medication. I miss about 1 day a week. And I would tell her, well, miracles like this haven't happened since biblical days. 1 Advair lasting most of the year. But they stuck to it. And I, to this day, don't know whether they're just really dumb or, complete liars. And it doesn't make any difference. The point is, we've identified the problem. Why this? So this is a case where it's not the asthma necessarily that's difficult, but the asthmatic that's difficult. In the meanwhile, she was getting albuterol refills about every 2 weeks. And our instructions to the pharmacy, said that the pharmacist was actually violating our instructions as to how often refills could be given. So the problem is there's a conflict between the history and pharmacy treatment data that was not being recognized by the patient and mother who just stuck to their history. So this is an important tool when you've got a patient who is not responding like you think they should. Get the printouts from the pharmacy of how often they're actually refilling things, and make sure they're only getting it from one place, and make sure they're not getting a bunch of samples from local doctors, which is another thing you need to make sure of, that you have some control over the medications and you know how often they're actually getting them. The solution in this case, this girl had a major allergic component, and so we elected to treat her with ovelizumab, Xolair, the anti-IgE, very expensive medication, but in the long run, it was going to cost, as she was on Medicaid, it was going to cost the state less than all the emergency room visits she was having, And in fact, it did cause a major reduction in the emergency room visits with no hospitalizations over the following year. So this just involved her coming in every 2 weeks for a shot, which she did pretty regularly, and it was effective. So, continuing on, when asthma doesn't respond, there are other reasons. And one reason is because it might be difficult because it's not asthma. And let's look at a few cases, see if we have some time for them. Here's a 10-year-old girl coughing for 9 months. Harsh, dry, barking cough. It's incessant most of the day. It's occurring multiple times per minute. Treated with, before we saw her, she had been treated with prednisone, theophylline, aerosol bronchodilators. No response. Very nice girl from an upper middle class family in the northern suburbs of Chicago. They actually traveled over 200 miles to come see us. She'd had 2 hospitalizations for IV treatment to try and treat the cough. And despite the fact she was a good student and had many friends, this was preventing, the cough was so persistent during the day, it was preventing school attendance. This is not the girl, but this was happened to the video I have of the same sort of cough. Stillwell, in a talk earlier in the week, I said, when you hear that cough, everyone in the clinic knows what the diagnosis is. And again, the key is it's not present once they're asleep. So this is the habit cough syndrome. The clinical characteristics are this loud, repetitive, dry barking cough, goes on for weeks or months, irritating, disturbing to others, prevents school attendance, commonly misdiagnosed as asthma. Almost everyone we've seen has been misdiagnosed as asthma. There is no response to any medications. It is absent once asleep. That's the giveaway. And you have to ask, they may cough while they're trying to go to sleep, but once they're asleep, it's no longer present. Virtually every organic cough is present while they're sleeping. Treatment is suggestion therapy. This is a publication we had a number of years ago. Looking at the long-term outcome, 8 of 9 patients were treated successfully with 15 minutes of session. 1 of 9 required 30 minutes. Very skeptical 14-year-old, very bright boy who was planning to go into artificial intelligence, and he was just skeptical that we were going to talk him out of coughing. It took 30 minutes. We did see some minor relapses that were treated with what we call auto-suggestion technique. One required a second session 9 days later, and all remained asymptomatic for a median of 2.2 years after that. What's important about this is, as successful as we were here, if you don't do something specific, you end up with much worse outcomes. This was a study that my colleague up at Mayo Clinic, after hearing about our results, had one of his fellows look at their long-term outcome of habit cough syndrome. And the follow-up of 62 patients for a mean length of 7.9 years. So they had a lot of patients with that diagnosis, but they had no specific treatment. They would just diagnose it. This is what they had, explain it to the family, and that was it. The ages were about the same as the ages of our patients, and the mean duration until the diagnosis was about the same as our patients. But the mean duration till resolution, after being seen at Mayo, was another 6 months, and 16 patients were still coughing an average of 6 years later. So this has caused a lot of morbidity, and yet it is very, very easy to treat with various types of what I call suggestion therapy. There's various techniques that have been used in the literature. I don't know that ours is any better than others. I'm just an impatient one, so I developed one that took 15 minutes. But there are other techniques that work. Continuing on, 9-year-old girl with a cough for 2 years, harsh, dry, barking cough, paroxysmal coughing with post-tussive emesis. She had nightly awakening from cough. This cough sounded a lot like the habit cough when you listened to her, but nightly awakening from cough. She'd been treated with bronchodilators, theophylline, and prednisone. She'd had enough prednisone that she was Cushingoid, hirsute, and growth suppressed. She'd been on virtually daily steroids for 2 years. She was severely Cushingoid. She'd had several hospitalizations. I didn't know what she had when I saw her, but I knew it wasn't asthma. Because asthma, you make someone Cushingoid, and they're still coughing. It's not asthma. So we took a look at her airway. Upper airway. Dim the lights just a little more for some of these. I'm going to have a few of these. So we're going down the trachea. This is the trachea. So keep watching the trachea, and the trachea should be round, and as we get towards the lower trachea, notice how it's collapsing. And shortly you'll see the anterior and the posterior walls actually touching each other. And while you doesn't show up well in the video, with the direct view, we could actually see that there were ulcerations where they were touching each other. And as we come out, you'll see that even more. And of course, anything that increased the airway pressure, the intrathoracic pressure with coughing would really make these things collapse. See how the anterior and posterior walls are coming together and kissing ulcerations at those 2 points. And so this was the focus of irritation for the cough. This, of course, is unusually severe tracheomalacia, much more so than the ones that are self-limited. And this is an 8-year-old girl. The tracheomalacia treatment, and tracheomalacia has been demonstrated in older children to have chronic cough. This is a study that was done by Bob Wood, who was kind of the granddaddy of pediatric fiber optic bronchoscopy. And he described 7 patients with chronic cough associated with tracheomalacia, and he treated about half of them with type of a behavioral technique, probably not all dissimilar from what I talked about with the habit cough syndrome, essentially breaking the cycle and decreasing the irritation. But a very small number do require and benefit from aortopexy, which is stenting the trachea using a stitch between the sternum and the aorta to place tension on the connective tissue between the aorta and the anterior wall of the trachea, which is what we did with this girl, and that cured her. Came off all medications, and she was cured with aortopexy. Again, that's not something we do very often. It's done quite uncommonly, but it was curable here. Another 4-year-old boy with a harsh barking cough, present since infancy, diagnosed as asthma. His allergy skin testing had been negative. A local allergist in Des Moines was taking care of him. He had been treated with Promolan Singulair, PRN albuterol, multiple courses of steroids. He had equivocal response to all treatment. And we did a bronchoscopy, and what we saw was this thing, which took me a bit of thinking, but I figured that's the uvula, and it's sitting down there, sitting on top of the epiglottis. And it was interesting when we got some more history. This is a very bright 4-year-old boy. We asked him why he coughed, and he says, "Well, I feel something in the back of my throat." The mother also made some other interesting observations. He would start having spasms of coughing. If he drank water or chewed gum, it would stop. So something lubricated this. He would feel better. If he would sit in his car seat, in the back seat of the car, with the window open and his mouth dried out, that would make him cough. And she'd give him some water and it would stop. So I asked our pediatric otolaryngologist, does the uvula serve any useful purpose? He said no. So they took out the uvula and his coughing stopped. Okay, some others. Jennifer, 15-year-old girl with 3 weeks of wheezing and dyspnea. She had a first episode, detasseling. How many of you know what detasseling is? A few Midwesterners, huh? Okay. Well, a lot of teenagers get jobs detasseling. It's how you make hybrid corn. They go and pull off the pollen-making things off of the corn so that they don't auto-pollinate, that they pollinate across between rows so that you get a hybrid corn. And so the teenagers get this job. It's a hot, dirty job, but they make some quick money. She had a second episode the next day while detasseling, acute respiratory distress, treated in the emergency room with epinephrine. But then she started having daily episodes without detasseling, without response to epinephrine. And the local doctor treated her as an asthmatic because they heard wheezing. And she got bronchodilators, theophylline, prednisone, hospitalization without response. She said that now this wheezing was starting with exercise all the time, every time she would exercise. And she was a very active girl. We put her on a treadmill and we exercised her. And here's her spirometry loop pre-exercise. And here it is post-exercise. And what we're seeing here is not asthma, not intrathoracic airway obstruction, but upper airway obstruction, as indicated by the flattening of the inspiratory flow lobe. And she did have a positive skin test to corn pollen, so this was essentially an occupational phenomena. She was having acute laryngeal edema from corn pollen, and somehow this triggered off this inappropriate response. And the treadmill exercise did induce this wheezing noise that she heard, but it was an inspiratory noise, not an expiratory noise, and it was diagnostic of extrathoracic airway obstruction. So her...
Can you stay over your shoulder at all?
Okay, now open your eyes and look in there. Okay, as we're breathing there, will someone point to the ancillary vocal cords? Swallow. Nice slow deep breath. Okay. And notice when you exhale, they open up. When you inhale and make a noise, you see how they're going together? That's the problem. They're supposed to open when you inhale. Okay? I want you to say something and make them move. Okay? Are you looking at it? Okay? Say 1, 2, 3.
1, 2, 3.
Okay?
Okay, vocal cord dysfunction. And there are different patterns of vocal cord dysfunction. I'm going to show one more girl with a very different pattern. This girl has been going on for a year and a half, several hospitalizations, emergency room visits, no consistent response to treatment. And here's her pulmonary function when she was not having symptoms. And this is before and after we were getting ready to do a histamine bronchoprovocation. But just getting out the syringes and the vials, she started the symptoms. We never had to actually bronchoprovocate her. And she had what was called wheezing. Here's her. This is a variation of vocal cord dysfunction.
Say E.
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 O.
O.
O. Okay, do that again. Say how.
How.
And how.
Go on to the next one because of time. Treatment of vocal cord dysfunction is speech therapy is the primary treatment, but we did find for those who have it just with exercise, that an anticholinergic inhaler, ipratropium, may block exercise-induced vocal cord dysfunction. It doesn't treat it once it occurs, and it doesn't treat like the second one where it occurs spontaneously. And we've got a publication that's in press on this coming out now. I'm going to, because of time, I'm going to, this was flexible laryngoscopy, a publication the pediatrics just heard out, just came out showing exercise-induced laryngeal malacia. That going to quickly talk about the diagnosis of exercise-induced dyspnea in those who were atypical for asthma. And we had 142 patients that we did exercise testing on. Only testing on had exercise-induced bronchospasm, 13 had vocal cord dysfunction, 15 had restrictive abnormalities, 2 had exercise-induced laryngeal malacia, 1 had exercise-induced hyperventilation. We had 1 with exercise-induced ventricular tachycardia, and the others had physiologic abnormalities, were physiologically normal, despite their complaining of exercise-induced dyspnea. They mistook normal physiologic limitation as being pathologic. And so exercise-induced dyspnea is definitely not always asthma and won't respond to asthmatic treatment. And you can identify this with appropriate treadmill exercise testing. So take-home message, difficult asthma may be a result of inappropriate assessment and treatment, poor adherence to the medical regimen and treatment plan, diagnosing asthma when the problem is not asthma. So assess, treat, and verify that they're taking what they're taking, and reassess if there's poor response to treatment, because there are these various reasons why asthma doesn't respond to treatment, or asthma is not asthma, which is why it doesn't respond to treatment. Thank you.